Well, thank you very much for this kind introduction and for inviting me to talk about self-disorders and schizophrenia today. Oh, let's see here. Okay, so here's my agenda. I will start with just say a few words about what is schizophrenia and then move on to the self in schizophrenia and the historical roots of this. And then talk a bit about the different concepts of selves and how they can be disorders. And then I will give a few examples of how self-disorders or how patients can talk about self or express self-disorders. And then I will move on to introducing you to the examination of anomalous self-disorders, or the EASE, which is a semi-structured interview that can be used for assessing self-disorders. And then I will end up with the empirical evidence of self-disorders being central for schizophrenia. Right. So I will start with asking the question, what is schizophrenia? And one obvious place to go and look for the answer could be in the diagnostic manuals, such as ICD-10 or DSM-5. However, one would find in the diagnostic manuals that here schizophrenia has been reduced to a combination of symptoms and signs, mostly psychotic symptoms such as delusions, hallucinations, form of thought disorders, and catatonia, but also negative symptoms. But this is in no way descriptive of the concept of schizophrenia or what schizophrenia is. So it doesn't help us that much. But somehow it is perhaps not that surprising, because the idea with the diagnostic disorders are not to be a comprehensive and exhaustive description of the single or the particular disorders. The point of the diagnostic criteria is to delimit the different disorders from each other. So I think as a delimitation of schizophrenia, these criteria might work better than to describe what it is. So in order to kind of approach what schizophrenia is, it might be relevant to look at some of the classical literature on schizophrenia and on psychopathology. And the classical psychopathologists from continental Europe, they all agreed that there is something phenomenological and typical about schizophrenia, something that is clearly distinct from other conditions, something that is characteristic for schizophrenia. And the prototypical cause schizophrenia do not consist of the fluctuating superficial psychotic symptoms. Here it might be relevant to mention that Bleuler, who coined the term schizophrenia more than 100 years ago, he thought that the psychotic symptoms were not important for schizophrenia. They could be present, or they did not have to be, that was not important for the diagnosis. He thought that the psychotic phenomena were accessory symptoms, and that some of the other phenomena, the non-psychotic phenomena, he believed were essential for the disorder or fundamental for the disorder. And schizophrenia consists of these traits that reflect the structure of the disorder or the core of the disorder. So these psychotic symptoms and negative symptoms are thought to be reflection of the core disorder. And today I will argue that the core disorder of schizophrenia is a disturbance of the minimal self. And actually, this is not a new idea, but it's sort of a rediscovery of an old idea. So I will start with the old idea about this core of schizophrenia and the historical roots. So the core disturbance, or what Minkowski called the trop générateur in schizophrenia, is a disorder of the self. And I have listed here Kraepelin, Bleuler, Jasper, Spertze, Minkowski, Schneider, and several other of the classical European continental or continental European psychopathologists wrote about this. For instance, Kraepelin, who wrote about dementia praecox, claims that a disunity of consciousness was a fundamental feature of schizophrenia, and that this disunity was linked to a peculiar destruction of the inner links of the psychic personality. And what might be relevant to mention here is that the word personality had a slightly different meaning at the time of Kraepelin and Bleuler than it does today. At that time, personality meant something more like the self, and is quite which is different from what we think about when we talk about, for instance, personality disorders today. And Bleuler, he was the one who coined the word schizophrenia, right? And he described ego disorders among the complex and fundamental symptoms. And here he's talking about the fundamental symptoms, which are the symptoms that had to be there for the disorder to be schizophrenia. And Minkowski wrote in 1927 that the madness does not originate in disorders of judgment, perception, or will, but in a disturbance of the innermost structure of the self. Also, Gruhle mentioned about or wrote about this, and he claimed that the schizophrenic basic mood manifests as a self-disorder or Ich-Störung, which is a disturbance of this feeling, this self-feeling that accompanies all our mental acts and states, and that this disturbed self-feeling is actually the foundation of what he called, or what was called, the automatisme mental. Then several years later, Kurt Schneider, who wrote about the first-rank symptoms, he argued that a specific alteration of experience was the generative matrix of the first-rank symptoms in schizophrenia. And he talked about a lowering of the barrier between the self and the surrounding world. So somehow the barrier between me and not me, or self and the surrounding world, became permeable or lowering, as the translation says. But also that it was a loss of the very contours of the self and a loss of identity. And he also used the German term Ich-Störung. And actually, much later in DSM-3R, the self is also mentioned. And here it is stated that the sense of self that gives the normal person a feeling of individuality, uniqueness, and self-direction is frequently disturbed in schizophrenia. And this is sometimes referred to as a loss of ego boundaries, and frequently is evidenced by extreme perplexity about one's own identity and the meaning of existence. But since then, the descriptions of the self seem to have been lost or from the diagnostic manuals. All right, so I've been talking about a self now, so we need to talk about what kind of self am I talking about, because there are several concepts of the self. And there's no doubt that schizophrenia involves a disorder of the self, but here we will only distinguish between two different kinds of or concepts of self. There are several others, but the ones I will concentrate on here are the narrative self and the minimal self. The narrative self, which is not the basic disturbance in schizophrenia, that's the minimal self, but the narrative self provides the answer to the question, who am I? And it includes sort of one's identity and characterological traits, in one's temperamental features, values, attitudes, and beliefs. And it is to a large degree shaped by interactions with other people and with the world. And it entails a nuanced and sophisticated understanding of the self's relation, dynamics, and social-cultural aspects. And the reason why I call it narrative is that it, at least partly, is a product of the story that I myself and others tells about me. So the narrative self is actually a quite complex self and quite sophisticated, in contrast to the minimal self, which is a very thin concept and notion of the self, but it manifests pre-reflectively as sort of a certain configuration of experience, and that experiences manifest themselves for me, in my first person perspective, that is that I pre-reflectively am aware that it is me who is speaking now. It is me who is experiencing. I do not have to reflect about thinking is going on, who is thinking, oh, it's me who's thinking. I pre-reflectively know this. And I'm always self-aware. So I don't need any kind of, not to think about that I am being myself. And all my experiences are permeated by this sense of self-presence. And this sense of self-presence persists across time and also across changing modalities of consciousness. That could be, for instance, whether I'm thinking, whether I'm listening, whether I'm remembering something. These are different modalities, but they are also always, these experiences are always saturated with the feeling of being me. That it is my experience, it is me who's listening, it is me who's remembering. And this sense of self-presence saturates the experiential field. So it is easy for me, it's usually not a problem to distinguish, is it me who's experiencing or is it someone else? So when we can have disorders of these kinds of selves, and if the narrative self gets disorders, it will usually show itself as inconsistencies in interpersonal relations, accentuated or inconsistencies in characterological traits, and also sort of a rigidity or instability of values, attitudes, and beliefs. And this is typically seen in personality disorders. So this is where, so in personality disorders, the self that is disturbed here is the narrative self. So if we see disturbances of the minimal self, where there is a failing self-ascription to mental states already at the pre-reflective level, so this, I'm not really sure if it is me who is experiencing or me who is thinking or listening or remembering. If I can't really take this for granted, then there is a disorder of the minimal self. And the experiential life becomes increasingly anonymized, alienated, and specialized. And a distant or a felt distance can emerge between the experiencer and the experiential context. That is, a felt distance between me and what I am experiencing. And here I use the word experiencing in the broadest sort of meaning. So it can mean all kinds of experiences, thinking, listening, remembering, as I have already used as examples. And this sense of self-presence no longer saturates the experiential field, rendering the boundary between me and not me frail or permeable, as Kurt Schneider also wrote, and allowing for another presence to emerge in the midst of my own experiential field. So things that, or experiences that usually cannot pass in and out, at somehow perhaps can anyway, or at least the patient can have the experience. And disturbances at this level, at the minimal self, that is what we see in schizophrenia spectrum disorders. So when I talk about self-disorders in schizophrenia spectrum disorders, I talk about this disorder of the minimal self. So if we look here in schizophrenia spectrum disorders, I've tried to make this difference between personality disorder and schizophrenia spectrum disorder and the narrative self and the minimal self. Because if a patient with schizophrenia spectrum, with a schizophrenia spectrum disorder have a disturbance of the minimal self, this can easily reflect on the level of the narrative self. If one, for instance, are not really sure whether I exist or not, then it is easy to see that that will also give problem at the narrative level of who am I. But it does not work the other way around. So if one is disturbed only at the narrative, or primarily at the level of narrative self, it does not reflect down to the basic self. So I think this is an important idea when trying to distinguish between schizophrenia and personality disorders. Okay, and here I have some examples of how this disordered self can show itself, or how it can manifest in schizophrenia spectrum disorders. Well, actually, there is sort of a linguistic important thing I need to address here, and it is there is a disturbance of the minimal self, and that is what I argue is the core problem in schizophrenia, and that is what we call the self-disorder. And we talk about it in singular, one self-disorder. The self can be disordered. And then we have all kind of different ways how this disorder of the self can be reflected. And sometimes we tend to call all these manifestations self-disorders in plural. But please be aware there is only one disturbance. So all the other things, if I call it self-disorders, I'm talking about manifestations of the basic self-disorder. And these self-disorders, as I have written in plural here, they are egosyntonic, they are non-psychotic phenomena, they are experiential features, which usually have a very early onset. Patients usually describe that they have known these experiences from early childhood or otherwise from early adolescence. I think it's important here to emphasize that self-disorders are non-psychotic phenomena. Obviously, they can evolve to psychotic phenomena, but then we will call the psychotic phenomena whatever term it is. It could, for instance, be a first-rank symptom, and then we would not call it a self-disorder or a manifestation of the basic self-disorder anymore. It would have to be on a non-psychotic level. But it can, for instance, be a feeling of being radically different from other people, which in German is called Anderssein. And it is important here to distinguish this experience for sort of the trivial notion of feeling different. We are all different, obviously, we're different from each other. But this is at a very basic level. I feel different as a human being, or perhaps even not feeling like a human being. I feel different in kind from other people. It can also be this experience of one's thoughts being somehow anonymous, that they are no longer saturated by the self-present, or they no longer have the tag of mindness. They do not feel like my thoughts. I had these thoughts in my head, but they don't feel alien, because if I start to think that it is different or alien thoughts in my mind, then we are on a psychotic level, but they do not feel quite as my thoughts. So they have sort of an anomalous feel to it. It can also be or manifest as a perceptualization of inner speech. And that would be that I, for instance, hear my thoughts spoken aloud inside my head, typically with my own voice, but that's not important. If it is, it can be with other people's voice or with an unknown voice. But what's important here is that there is no experience of other people having access to my thoughts. Because if other people start to have access to my thoughts, that I think if another person stood very close to me, he might be able to hear my thoughts as well, then we would be talking about thought broadcast, which is a first-rank symptom, and then we are on a psychotic level. So it's just the experience of hearing my own thoughts spoken aloud inside my head, but still private. It can also show itself as an estrangement of the body, that somehow I feel that my body doesn't really fit me, or it's wrong, or that that there is a distance between me and my body, that there is a felt distance, that I don't sort of fill out my body, that I'm smaller than my body, or something like that. It can also reflect in common sense problems, which is the experience of not having this pre-reflective experience of other people. Why do they do as they do? Why do we have these unwritten social rules, for instance? Why do we say hello when we meet each other? Don't have this sort of pre-reflective knowledge of this, or perhaps not being able to take for granted what other people take for granted. And this usually or often, if one person have problems with the common sense or lack of common sense and don't really understand things that other people take for granted, it often leads to hyperreflectivity, where they reflect intensively on themselves or aspects of the surroundings. For instance, a patient told me that he often sort of fell into to deep thoughts and deep hyperreflectivity about why the colors of the traffic lighting in the traffic, why we have chosen red, yellow, and green. He thought that was very strange, and he really thought a lot about that. So that's an example of hyperreflectivity. Then it can be transitivistic experiences. I think I've already touched upon that the barrier between what is me and what is not me or the surroundings is not closed as it usually is. It is somehow permeable or maybe transparent. So the patient feels not that everybody have access to my thoughts, but that they have some kind of access to me, that they can see something that they should not be able to see, but still be on a non-psychotic level. This can, of course, also, it's on a continuum, so it can move on to a psychotic level. And the last example I have here are the solipsistic experiences. I don't know if you're familiar with the word solipsism, which is sort of a philosophical position. The word solipsism comes from solo, meaning alone, and then the ipse, which means the self. So the self is a sort of in a lone position or in another position from other people. This patients who have this experience often have sort of a grandiose solipsistic experience, that I feel like I am more intelligent, I have larger or greater insight into reality or into other people's feelings or something like that. But it doesn't have to have this grandiose sort of feel to it. Oh, I can see something. There is a question here. Should I just see that? That has nothing to do with me. Right, so that was my the first examples. Then I have. Okay, and here I just took a bit more of an example of a patient who described a manifestation of the self-disorder, or actually several. It is a 35-year-old female who has felt profoundly different from other people since childhood. And when asked to describe this a bit more, she says that, well, she had felt because she has felt different because she thought it was so difficult to understand other people, and she still thinks it is. But when she was a child, she had some ideas that maybe other people could read each other's thoughts, because it was obvious to her that they sort of understood each other, but without talking about it. So perhaps they had some kind of access to each other's thoughts. And she says they possess a skill that I do not possess. So it's obvious for her that they know something about each other and about the world and sort of how to interact that she doesn't. And this points to experiences of both Anderssein and lack of common sense. All right. So now I hope that you have sort of the basic idea about the minimal self being disturbed in schizophrenia, and the idea is that that is sort of the core disturbance, or one of the core disturbance, or very close to the core disturbance of schizophrenia, and this is what sort of generates all the other manifestations, also the psychotic manifestations and the negative symptoms. In 2005, the examination of anomalous self-experiences, or the ESE, was published in Psychopathology, written by Joseph Parnas, who's a professor in Denmark, and several other people. The ESE is a semi-structured scale to assess self-disorders. And I will just say a little bit about the development of the ESE scale, because in the 1990s, the psychopathological importance of self-disorders were rediscovered. But as I hope my talk about the historical roots about schizophrenia made it clear to you that it was not a new discovery, it was just a rediscovery. And the preliminary findings back here, now we are in the 1990s, they were confirmed in 2 independent studies, one from the Danish group with Joseph Parnas, which were published in 1998. And then 2 years later, a Norwegian group with Paul Møller published sort of the same findings. And the 2 groups, they did not know each other at that time. Obviously, they got in contact after discovering that they were working on the same phenomena. And then they got together, and together with also a philosopher, Dan Zahavi, who's also a philosopher or professor in Copenhagen, they constructed and published the ESE scale in 2005. And this is the semi-structured instrument that can be used to examine for self-disorders. It contains 57 main items, and that is 57 different manifestations of the disturbed self. And these 57 items are distributed into several domains, and it allows for both a qualitative but also quantitative assessments of self-disorders. And again, I will just mention that these self-disorders are non-psychotic, and they are trait-like, meaning that they are present over a long time, that is years typically, or perhaps for some throughout life. And this is in contrast to state-like phenomena. For instance, a depression, that is a state phenomena. There the depression will be there for a while, and then it will be treated, or it will pass by itself, and then there will be no signs of this. So this is more a state phenomenon, in contrast to these self-disorders, which are trait, will be present for years. They can fluctuate in intensity, but it will always be present. And these manifestations of the self-disorders, they are considered to be interdependent aspects of this psychopathological gestalt. So we often see many of these phenomena appear together, in certain patterns. Like I said before, patients who have a lack of common sense usually also experience hyperreflectivity, because when there isn't this pre-reflective or this just understanding other people, then they need to reflect about it, and that often leads to hyperreflectivity. Okay, the ESE have been tested psychometrically, and we have shown that it has an excellent internal consistency. It has a monofactorial structure. We have just published, we have found that several times, and another group than ours here in Copenhagen has also found it. And we just published a paper in Schizophrenia Bulletin here in 2023, where we tested it again and again, found a monofactorial structure. And it is possible to to achieve good to excellent inter-rater reliability among trained, experienced clinicians. And that has been found both in our group, but also many other groups. The publication of the E-scale stimulated a lot of research worldwide in self-disorders. And in 2021, I and two colleagues published a systematic review in Lancet Psychiatry about the empirical evidence of self-disorders, because self-disorders, to some degree, this idea, the rediscovery was to some degree on a more theoretical level. So we needed to see if these ideas also held true when we examined patients. Okay, so here is the flow charts of the systematic review, and we searched 4 different databases and ended up with including 53 studies in the review. What is important to say here is that we excluded it because self-disorders need to be examined by an experienced examiner, and also in a face-to-face examination, even though there are several self-questionnaires published, they have not been validated, and it's not possible to examine for self-disorders because it is so subtle experiences, and they are often mistaken for quite trivial experiences. Like I just said before, do you feel different than other people? Well, many people will say yes to that because we are different, right? So it's different. The quality has to be on a certain level. It has to be different as a human being. So we needed, in order to have valid data and result, we needed empirical studies who had in which the patients were actually examined in face-to-face interviews, in a clinical interview. And we did not only include studies which had used the E-scale, but also other kinds of scales. Usually scales that were made before the E's. There were a pre-E scale which several studies had used. And if they had included at least 10 items, we would include it in the review. And there needed to be at least 10 patients included in the study to be included. Okay, so we ended up with these 53 studies, and I will present the results here. The first result is that self-disorders definitely hyper-aggregated in schizophrenia spectrum disorders. 24 of the studies that we examined looked at the distribution of self-disorders in different clinical groups and also in healthy controls. And we found that self-disorders consistently hyper-aggregate in schizophrenia and schizotypal disorder. So when I talk about schizophrenia spectrum disorders, I talk about schizophrenia and schizotypal disorder. But they did not aggregate in other mental disorders or in healthy control. It is not like they are pathognomonic for schizophrenia. Of course, we can see them in other patient groups than in schizophrenia, but there are a much higher level of self-disorders in schizophrenia spectrum. The review showed that self-disorders also occurred in first episode psychosis and in clinical high-risk patients, and also in ultra-high-risk groups. And the data suggest that these self-disorder scores may be more reflective of a schizophrenia spectrum disorder than of the severity of the clinical stage. And here I have listed some of the studies who have looked at different disorders and also healthy controls. And within this red frame, you can see how the patients scored on the E's in schizophrenia and schizotypal disorder. And what you perhaps can see is that there seems to be a trend that they score a bit higher on schizophrenia. That, for instance, Raballo and Parnas, they score 21.4 for schizophrenia and 17.0 for schizotypal disorder. But statistically, the difference is not significant, but there seems to be a trend. It is probably this lack of difference could be because of a lack of statistical power to show it, because we are working on a publication right now where we have pooled data from 226 patients who have all been examined with the EASE. And here it looks like that we actually do find a significant difference between schizophrenia and schizotypal disorder. But still, patients with schizotypal disorder score high on the EASE, but patients with schizophrenia even higher. Right? And as you can also see from this slide, that other groups, also healthy controls, do score something on the EASE, but not that much. And what is important to say here is that there are a few items included in the EASE manual which are not specific for schizophrenia in any way. And that is, for instance, that there are 5 anxiety items, and anxiety can be seen in all conditions and also in healthy people, right? So that is why it's not surprising that also even healthy controls can score on the EASE scale. Okay, and here all the 24 studies are included in a weighted mean, and where you can see that on average patients with schizophrenia scored 20.7, and patients with schizotypal disorder scored 19.7. And then other groups did score something on the EASE scale, but there is a significant difference here. And for instance, bipolar scored 6.3, so very low on the EASE scale. And here I have a terrible slide, but I will tell you sort of the point from it, because in this is another study. This is also for 2021. It is by Andrea Raballo and colleagues. Also Joseph Parnas is an author of this, which is a meta-analysis of the empirical studies on self-disorders. And what they have done here, see if I can point, is that here first they have listed schizophrenia patients versus healthy controls. And then, as you can see, this rump here is located far away from, or some space away from the line, meaning that there were a significant difference between what healthy controls scored on the EASE scale and schizophrenia patients. And for the next one, it's other mental health illnesses versus schizophrenia, which there is also a significant difference. The third one, bipolar or other affective disorders versus schizophrenia, also a significant difference. And then there is the ultra high risk, also a significant risk difference. Schizotypal disorder, there's no difference between schizotypal and schizophrenia. And then the last one is first episode psychosis, where there is just a little difference, a very small difference, significant difference between schizophrenia and first episode psychosis. Okay, so that was sort of the hyperaggregation of self-disorders in schizophrenia spectrum disorders. That was the first finding of the meta-analysis, from the systematic review. The second result is that we looked for the temporal stability and the predictive value. The temporal stability of self-disorders are important to test if the idea that self-disorders are a trait phenomenon present over years. So it was important to see, was that actually what we could find in the studies. And We did find that self-disorders seem to be temporarily stable over 5 to 7 years. Until now, that is the longest follow-up. 7 years is the longest follow-up period which has been done. But here in Copenhagen, we are right now doing a 20-year follow-up on self-disorder. So we will see if how that looks, but we are still re-examining the patients, so it's too soon to say anything about that. And the correlations between self-disorder scores at baseline and follow-up across the studies ranged from 0.5 to 0.6. And it also seemed that self-disorders have a predictive value because high levels of self-disorders at baseline predicted schizophrenia spectrum disorders in patients initially diagnosed outside the spectrum, but now then diagnosed with schizophrenia spectrum disorders. And also it predicted later schizophrenia spectrum disorders in help-seeking young adolescents. And they also predicted a transition to psychotic disorder in an ultra-high risk sample. Okay, and then we finally looked at the correlations between self-disorders and a lot of other variables in the systematic review. And there were a lot of different variables tested, but I will just mention a few of the main trends here. And that is that self-disorders, they correlate with the canonical dimensions of psychopathology of schizophrenia, such as positive symptoms and first-rank symptoms, negative symptoms, and disorganized symptoms, and perceptual disorders as well. And self-disorders, they correlated with impaired social functioning and suicidality, but they did not correlate with neurocognitive deficits or childhood trauma. But it is important here to mention that I don't think there have been, I'm not aware of any studies that have examined patients with an IQ below 70 for self-disorders. I'm not sure it's really that feasible to do it because it does require, to examine a patient for self-disorders do require that they have a certain degree of being able to reflect and also a certain degree of linguistic maturity. So it has not been tested. Okay, so to conclude on all I have said so far is that self-disorders, they do hyper-aggregate in schizophrenia spectrum disorders, and they are relatively stable over time. And they do have predictive value for development of schizophrenia spectrum disorders. And they correlate with the classical dimensions of the classical psychopathological dimensions of schizophrenia, but not the neurocognitive disorders. And that they can be examined systematically with the ease. So all these findings, all the empirical findings, substantiate the idea that schizophrenia or self-disorders are the core of or somewhere very close to the core of schizophrenia. Yeah, what I have not included in my slide, but my slides, but is probably relevant to just mention a bit about is the treatment of self-disorders. And the short story is that we do not know how to treat them. It has not really been examined. We are quite sure that probably the best way to treat these are by psychotherapy, and there is a need of developing psychotherapeutic methods to address this. There have been a few papers sort of sharing ideas on how could this perhaps be done, but they have not been tested. What we have experienced from in Denmark, but it's just on a sort of an anecdotal level, we have not done any research on it, is psychoeducation about self-disorders. We did some groups with young patients just diagnosed with schizophrenia, and for instance, in the group, the theme of the day could be undersign, and then we would explain what is undersign, this feeling profoundly different, feeling different as a human being. And then we would ask the group, did anyone recognize anything in this? And for instance, there was one time in a group where one patient said, well, yes, I really recognize this. I have always had a feeling like I was born in the wrong age, that I should have been born in the Stone Age. And then one of the other participants says, oh, how interesting, because I have always thought that I was from the Iron Age. And then a third person said, I feel like I have always thought that I was some kind of an alien, perhaps from outer space or something like that, because I felt so different. So on an anecdotal level, it seems like these patients really benefit from talking about these experiences, sort of not feeling like they were the only one in the world having these experiences. We also do, but that is also on an anecdotal level, we do give patients, if the antipsychotic medication, if the self-disorders are very psychosis near. For instance, if I have so much transitivistic disturbances that it's difficult for me to go in the street to go shopping because other people get too close to me and I get anxiety because of that. Then on an anecdotal level, it seems to have some effect to give smaller doses of antipsychotic medication. But there's definitely a need for research into treatment of this. And of course, if the patient has full-blown schizophrenia, of course, regular schizophrenia treatment is relevant. But especially perhaps for the patients with schizotypal disorders, which are usually not psychotic, or if they have psychotic experiences, it will be very brief. It has to be sort of on a micropsychotic level. So that would be very brief experiences. So we would usually not treat that with antipsychotics. But I do believe that there are some research going on around the world trying to look at a treatment for the self-disorders. And I think perhaps also it's important to say that in the systematic review that we did, all these 57 studies, they came from all over the world. Some of them were made in Copenhagen. We have definitely done quite a few empirical studies in Copenhagen on self-disorders, but a lot of other groups of whom we are not connected have also worked with this. Yes, I think that was what I had planned to say today. I have not used a full hour, but I hope that you will have some questions so we can discuss this. Thank you.